Head Injury by Rosalind Salmiana.
And now, the part of the brain, performed by the brain.
Yeah. Neocortex, frontal lobe, hippocampus, neural node, right hemisphere, pons and cortex, visual, Sylvian Fisher, pineal, left hemisphere, cerebellum left, cerebellum right, synapse, hypothalamus, striatum, dendrite. Axon fibers, matter gray, central tegmental pathway, temporal lobe, white core matter, forebrain skull, central fissure, cord spinal, parietal, diameter, meningeal vein, medulla oblongata, and lobe limbic, microelectrodes, the brain. That ought to keep the little squirts happy. Yeah.
Here are some major parts of the brain with its function. The frontal lobe is responsible for the executive functions, thinking, planning, organizing and problem solving, emotions and behavioral control, and personality. Parietal lobe is responsible for perception, making sense of the world, arithmetic, and spelling. Occipital lobe is responsible for vision, while temporal lobe is responsible for memory and hearing, understanding, and language. The cerebellum controls muscle coordination and balance, while the brain stem is responsible for our consciousness and breathing. Remember, damage to a particular area can affect that activity, and that the right side of the brain controls the left side of the body, and that the left side of the brain controls the right side of the body due to the crisscross networks of vessels. So what is head injury? It is a general term used to describe any trauma to the head, which may or may not include an injury to the brain itself. It is the most common cause of death from trauma resulting from vehicular accidents, fall, contact sports, physical assaults, or abuses. High-risk groups are the males aging from 15 to 24. Some of the percentage goes to the pediatrics and elderly. In head injury, patients may have loss of consciousness or an alteration in the level of consciousness, no matter how brief. Skull fractures, facial wounds or bruises, and discharges on the orifices. So head injury is classified into two. In a closed head injury, the skull is intact, while in an open head injury, the skull is penetrated by an object, like in a gunshot wound, or there could be a deep scalp laceration that requires suturing. Types of head injury. Scalp lacerations are the most minor type of head injuries, but the scalp is rich with blood vessels that even a minor cut can produce profuse bleeding. Scalp wounds are also portal for infection. Therefore, aseptic suturing and changing of dressing is a must. Concussion. It is a temporary loss of consciousness with no apparent structural damage. The jarring of the brain results to the disruption of neural activity. Patients may exhibit a brief change in LOC, vomiting, seizure, headache, and change in motor coordination that are short in duration. Treatment involves observation until signs and symptoms are fully recovered. Contusion. It is a bruising of the brain tissue caused by bumping or hitting your head into a hard surface. Bruise results from the blood leaking from these injured blood vessels into the tissues as well as from the body's response to the injury. It is associated with cerebral edema and therefore is more severe than concussion. Patients may have longer periods of unconsciousness with more symptoms of neurologic deficits and changes in vital signs. It is usually associated with closed head injury, a coup-contre-coup injury. Prognosis is dependent on the amount of bleeding around the contusion site. So what is a coup-contre-coup injury? These are French terms that mean blow and against the blow. A coup is an injury to the cerebral tissue direct to the point of impact. It is the result of a sudden, violent stop that causes the brain to move forward and hit the side of the skull. A contre-coup is an injury directly opposite to the point of impact. So when the brain suddenly moves forward and hits the side of the skull, it then bounces off the other side of the skull where the secondary or contre-coup injury occurs. A very good example of this is that when your car suddenly halts, your head keeps on moving until it can go no further, and your head comes to a sudden stop. After your head stops, it is likely that your head will rebound and travel backward. In both cases, the brain is damaged as it rubs against the inner ridges of the skull. Diffuse axonal injury, or DAI, involves shearing, tearing, and stretching of nerve fibers or axons, disrupting the communication pathways of the neurons, resulting from acceleration-deceleration motion, not necessarily an impact. When your head is shaken suddenly, such as in a car wreck, energy is transmitted to the brain and the brain moves. Because different parts of the brain have different densities, some parts of the brain move faster than the others, causing them to slide over each other. The energy applied to the brain causes it to bounce and swirl around within the skull, causing widespread trauma. As a result, the fiber twists, stretches, and may even tear. The nerves no longer communicate with each other as efficiently because the stretching and the tearing of the nerve fibers damage the brain's wiring system. Diffuse axonal injury commonly results in coma or death, increased ICP, decerebrate decorticate posturing, and global cerebral edema. Skull fractures. Skull fracture is a break in the bone surrounding the brain and other structures within the skull. Although the skull is tough, resilient, and provides excellent protection for the brain, a severe impact or blow can result in a fracture of the skull. It may be accompanied by injury to the brain. It is usually associated with localized persistent pain. It could be linear, depressed, or basilar. Linear skull fracture. A linear skull fracture is a simple break in the skull that follows a relatively straight line. A common head injury, especially in children. It can occur after seemingly minor head injuries, like falls, blows such as being struck by a rock, stick, or other object, or from motor vehicle accidents. Depressed skull fracture is a break in a cranial bone with depression of the bone in toward the brain. Compound skull fracture involves a break in or loss of skin and splintering of the bone. These are common after forceful impact by blunt objects like hammers, rocks, and other heavy but fairly small objects like stones. Surgery is often required to elevate the bony pieces or remove the broken bone. Basilar skull fracture or basal skull fracture is a fracture of the base of the skull, typically involving the temporal bone, occipital bone, sphenoid bone, and or ethmoid bone. Such fractures can cause tears in the membrane surrounding the brain or meninges, with the resultant leakage of CSF. So what are the signs of basal skull fractures? Raccoon eyes. This refers to the periorbital bruising, resulting from a blood tracking down from the skull fracture site to the soft tissue around the eyes. The battle sign. This is the bruising around the mastoid process, or behind the ears. It is a bruising due to the blood tracking from the skull fracture, not from damage directly to the mastoid process. Otorrhea. This is a leakage of CSF out from your ear via a combination of a ruptured tympanic membrane and the nearby basilar skull fracture. Rhinorrhea. This is a leakage of CSF out from your nose. Cranial nerve pulses. Many of the cranial nerves run nearby enough to be injured or compressed by a fractured base of skull. Patients may have facial Bell's palsy, difficulty hearing, tinnitus, and many others. So how to know if fluid coming out of your nose or ears is CSF? It could be pure blood, or in the case of nasal discharges, it could be just a normal nasal secretion. So there are a number of tests you can do. First, check the glucose content of CSF. It should be positive, whereas negative in nasal secretion. Second, if you are dealing with a bloody fluid, it would be difficult to know if CSF leaks because both blood and CSF have glucose. So you could try to look for the halo sign or the ring sign. Just dab some of the blood on a gauze and air dry. It should not cross from drying. If there is CSF mixed with the blood, the CSF will move by capillary action further away from the center than the blood will. So you will be able to get a picture of this. These tests are helpful pointers, but they aren't wholly accurate. If you want to be more sure, measure the level of beta-2 transferrin in the fluid. This protein is only found in CSF. Intracranial bleeding or hematoma occurs when a blood vessel ruptures within your brain or within your skull and your brain. The collection of blood or hematoma compresses your brain tissue. So let's now take a look on the layers of the meninges where hematomas accumulate. Sequence of the major layers from the skull are the dura mater, the arachnoid, and the pia mater. Bleeding between the skull and the dura is called epidural or extradural. Bleeding between the dura and the arachnoid is called subdural, and bleeding between the arachnoid and the pia mater is called subarachnoid. Epidural hematoma forms between the skull and the dura mater, the tough outer membrane that covers the brain. Epidural hematomas are most commonly seen in conjunction with skull fracture. Classic signs include initial period of unconsciousness, brief lucid interval followed by decrease in LOC, headache, nausea, vomiting, and focal findings. Epidural hematoma often occur with frontal and temporal bone injuries. The temporal bone is the thinnest part of the skull bone and is also the location of the middle meningeal artery, causing severe hemorrhage. The increasing pressure pushes the hematoma against the brain tissue and causing significant damage. Subdural hematoma forms between the dura and the arachnoid. The stretching and the tearing of bridging veins between the arachnoid and the dura mater due to the sudden blow to the head or change in velocity causes this type of bleeding. Subdural hemorrhage is a classic finding in shaken baby syndrome, in which similar shearing forces classically cause intra- and pre-retinal hemorrhages. Subarachnoid hematoma forms between the arachnoid and the pia mater. While this can irritate the brain and cause symptoms of headache, vomiting, and stiffness, treatment may be watchful waiting without surgery unless symptoms worsen. Intracerebral hematoma results from accumulation of blood within the brain, caused by bleeding in and around the brain. Size and location of hematoma determines patient outcome. The major goal of nursing care is focused on preventing increased intracranial pressure, or ICP. ICP is the pressure exerted by the contents inside the cranial vault. These are the brain tissue, composed of the gray and the white matter, which is 80%, the CSF, which is 10%, and the blood volume, which is 10%. Remember that the intracranial vault is a closed structure with a fixed intracranial volume. Therefore, the intracranial contents must be kept in equilibrium and the ratio between the volume and the pressure must remain constant. Any increase in the volume of one component must be accompanied by a reciprocal decrease in one of the other components. When this pressure-volume relationship becomes unbalanced, ICP increases, like in a traumatic head injury, where there is bleeding or swelling. The rigid cranium does not allow any expansion, and therefore ICP increases. Pressure of blood vessels within the brain causes blood flow to the brain too slow, leading to cerebral hypoxia and ischemia. When ICP continues to rise, brain may herniate and may compress the brain stem, causing death. So what are the nursing responsibilities? Monitor level of consciousness using the GCS. Changes in it is caused by increased ICP. Monitor papillary changes. Compare both eyes. Changes in it relate to location and progression of brainstem herniation. Maintain airway patency. Decreased PO2 causes cerebral vasodilation, thus increasing ICP. Monitor vital signs. Promote adequate ventilation. Increased carbon dioxide levels increase cerebral edema, resulting to increased ICP. Maintain cerebral perfusion by keeping the BP normal and avoiding hypovolemia. But some neurosurgeons prefer their patients to be hypertensive, just to ensure cerebral blood flow. Watch for increased ICP like the presence of Cushing's triad, like bradycardia, hypertension with widening pulse pressure, and irregular respiration. Monitor for signs of sympathetic storming like altered LOC, tachycardia, diaphoresis, tachypnea, hypertension, hyperthermia, and agitation. Monitor and protect the child if seizure occur. Observe and record the type of seizure. Avoid positions or activities that may increase ICP. Keep the head in alignment with shoulder. Neck flexion or rotation increases ICP by impeding venous return. Keep cervical collar unless cervical spine injury has been ruled out. Keep the head elevated 30 degrees to reduce jugular venous pressure, thus decreasing ICP. Minimize suctioning. Keep the procedure less than 15 seconds. Coughing and suctioning are associated with increased intrathoracic pressure, which is associated with increased ICP spikes. Minimize other stimuli such as auditory, visual, tactile that could precipitate increased ICP. Measure INO strictly and avoid hyperglycemia. Prevent infection if there is drainage from ear or nose. Place a dry, sterile, loose gauze. Do not pack ears. Let it drain. If drainage from nose is positive from CSF, do not suction the nose. Do not put NGT or any other instrument. Monitor laboratory values. And keep safety measures at all times. Mannitol. This is an osmotic diuretic. It raises the osmolarity in the nephron of the kidney so that more water is taken out of the body to be excreted. Nephrons are small units in the kidney that absorb nutrients, dumps waste, and regulates the balance of water to create urine. Osmolarity measures the amount of solute like sodium. Remember, if there's sodium, there's water, because sodium attracts water. If the body has too little water, the nephron will not allow much water to pass out of the body. But if the body has too much water, like in the presence of cerebral edema, the nephron will pass water and sodium out to be excreted with other waste as urine. This is how the drug is used in its capacity to decrease ICP, by drawing water out of the body, lowering the volume of extracellular fluid, thus relieving pressure. So what to monitor if a patient is using mannitol? Monitor the vital signs. Watch for hypotension. Monitor INO. Watch for dehydration. Monitor the electrolytes. Laboratory values like the PT-PTT, kidney functions. Store the mannitol in a room temperature. Crystallization may occur at low temperature. Do not use solutions that contain crystals. Heating in a hot water bath may be utilized for resolution of the crystallization. Cool solutions to body temperature before using. Prevention. Always use safety equipment during activities that could result in head injury. These include seat belts, bicycle or motorcycle helmets, and hard hats. Obey traffic signals. Be predictable so that other drivers will be able to determine your course. Be visible. Do not ride a bicycle at night unless you wear bright, reflective clothing and have proper headlamps and flashers. Use age-appropriate car seats or boosters for babies and young children. Make sure that children have a safe area in which to play. Supervise children of any age. Do not drink and drive, and do not allow yourself to be driven by someone whom you know or suspect has been drinking alcohol or is otherwise impaired. Remember, prevention is always better than cure. We don't want to end up like him, right?
And now, the part of the brain, performed by the brain.
Yeah. Neocortex frontal lobe. Hippocampus neural node, right hemisphere. Pons and cortex visual. Sylvian Fisher pineal, left hemisphere. Cerebellum left, cerebellum right. Synapse hypothalamus, striatum dendrite. Axon fibers matter gray. Central tegmental pathway, temporal lobe. White core matter, forebrain skull. Central fissure, cord spinal, parietal. Diameter, meningeal vein, medulla oblongata and lobe limbic. Microelectro